Yes, we are now recording.
Excellent.
Thank you, Carol. Wow. Sounds like I certainly have big shoes to fill, being part of the A-team. It's amazing. Thank you so much. I am very, very excited to have with us the panelists today that we have. So this starts our portion of the symposium for healthcare. So welcome, everybody. We are very, very fortunate to have with us today Dr. Gayle Thomas, the Medical Director of the North Carolina Farmworker Health Program. And she represents the North Carolina Department of Health and Human Services Office of Rural Health. We also have with us today Dr. Sallie Allgood, PhD. She's a registered nurse, also with the North Carolina Department of Health and Human Services Office of Rural Health, and she is their community development specialist. In addition, we have a couple of our very own. So,
all right.
We have Jennifer Norville. She holds a Bachelor's of Science in Public Health, and she's the Director of Health Occupations. She's a community health worker instructor, and she's got her hands full. Is the phlebotomy, CPR, and TABE test coordinator here at Edgecombe. Last but not least, Sue. Thank you so much, Suzi, for being here. Miss Suzi Shippen Wagner. She holds a Bachelor of Science in Healthcare Administration and is a certified surgical technologist and the Surgical Technology Program Chair here at Edgecombe. So in respect to the academic freedoms and extensive expertise of our panelist members, representation of content and topics is allowed with much freedom. So freedom of representation is allowed here in our panel. And the focus of this panel is to discuss how COVID has affected the various communities within our state and beyond. And discuss the healthcare services provided to those communities and how they may have been affected or changed. And think about the various ways in which disparities in healthcare are evidenced, not only through COVID, but just, in general, but how that has been reflected through COVID. And the pandemic. So I'd like to now defer to Dr. Thomas. Dr. Thomas, how are you today?
I'm good. Thank you so much for inviting me.
Hi, thank you so much for being with us. I'm honored. We're very honored. So Dr. Thomas, so we're kind of allowing for presentation of PowerPoint, open discussion. Do you have anything that you would like to share with us first and foremost?
Yeah, I have a short PowerPoint. If I can figure out, this is my first time in this web platform.
Great. So
I'm sharing it. When I try to share a tab, that didn't work. When I tried to share,
you may need to share a window.
A window?
Yes.
Yeah, I think it's easier to share in a window.
It's
or either your screen.
Be sure you have the PowerPoint open, and then try sharing the window.
Okay. I thought I had it open, but let me go back to it and then try it again.
Technology can be our friend, but it can be
there. Now I see it better. Okay. Good. All right. I hope that you guys can see my PowerPoint now.
Absolutely.
And I'll start from the beginning. Of course, now this means I can't see you or the chat, but anyway. So I'm going to talk a little bit about the farm workers in North Carolina and some of the health disparities that the pandemic sort of have really illustrated for us. Of course, you all know that we eat because farm workers feed us, that 85% of fruits and vegetables in the U.S. are still hand harvested, and that here in North Carolina, we're number 6 in the nation in terms of the number of farm workers in our state. Farm workers in North Carolina are primarily Latinx individuals. We estimate that we have about 100,000 farm workers and their dependents in our state at the height of our agricultural season. And most of them are limited in their English proficiency and prefer to speak Spanish, although there are also about 10% that have indigenous languages other than Spanish. As I said, most are Latinx, most are below the 200% of the federal poverty guideline, and 93% are uninsured. There are two types of farm workers. There's seasonal farm workers and migrant farm workers. And seasonal farm workers don't move for work. They generally live in family units, and they may have other work during the winter when there's no agricultural work available to them. Migrant farm workers, on the other hand, move for work. And we think that probably most of our farm workers, the majority of our farm workers in North Carolina, are migrant farm workers. They may come from Mexico or Central America, or they may come from other states. So we do know that we have 22,500 H-2A workers, which is a guest agricultural work visa. So these workers are here with documentation. That most of them come from Mexico, a few come from Haiti. And last year we had 22,500. They're registered with the government. They're much easier to track and find. The rest of the migrant farm workers are not H-2A workers, and many of them come from Florida. You know, Florida, the growing season is the winter down there, the opposite of ours. So they'll work down there in the winter, and then they'll travel up the East Coast following the crops during the summer. And we're already starting to see a lot of people from Florida come up to start to help us with our berry harvesting. And then they'll go further on up, even up until Maine, to help with berry harvesting up there. So we call that the East Coast migrant stream. Then there's one in the middle of the country, as illustrated by the red arrows, and then one in the west of the country as well. This group of H-2A farm workers that I mentioned that are here on the guest agricultural visa come for very specific months, often March through November, and they come, as I said, often from Mexico. About half of them come specifically through a collaboration of growers called the North Carolina Growers Association. The other half will be brought in by farm labor contractors. The North Carolina Growers Association gathers all their farm workers in one town in Mexico. They all come up together on the bus, about 40 to 50 hours, and come straight through to Vass, North Carolina. And this is a picture of them on this long bus ride that I clipped off of a movie about this. Here they are being processed at the Growers Association in Vass, North Carolina. Their paperwork is processed, and then they're transported to be picked up by their growers in work groups. Migrant farm workers are generally housed by their employers in work camps. And so this is migrant housing. Unfortunately, it's often very crowded. It's substandard. There are standards in North Carolina law that apply to migrant housing, but there aren't many inspectors, and so often even these minimum standards are not met. So there's no requirement for there to be partitions between toilets or between showers. There is requirement to be hot and cold running water. There's no requirement to have a washing machine, but just to have a sink for washing. So the requirements are very basic, and even those are not always met. The housing is often isolated and hidden. If you don't know where to look for it, you won't see it, and that is on purpose. It's often in the middle of a field or behind a grove of trees at the end of a gravel road. The workers are dependent on the employer for transportation. They're often transported to and from the work site in old school buses. So when you see a school bus out in the middle of a field, you know there's migrant farm workers there. Because of the history of our labor laws, these farm workers are exempt from the labor laws that most of us take for granted. So we take for granted a 40-hour work week with overtime, with paid time off for medical appointments and things like that, but they have no paid time off, no vacation time, no sick time. no overtime. They often work sun up to sundown. They get up in the dark and they're on their bus as the sun is coming up so they can be in the fields as the sun comes up. And they often don't get back until the sun is going down. They work 6 days a week, usually. Sunday is their only day off. And they're often paid by the bucket rather than by the hour. So this guy running with these sweet potatoes, that's probably a 50-pound bucket of sweet potatoes, and he's going to get paid about 44 cents for that bucket of sweet potatoes that he has gathered by hand and put on his shoulder and run to the truck and dumped it in. So our North Carolina farm workers have an average income of about $11,000 a year. This work is dangerous. It's the second most dangerous, agriculture in general is the second most dangerous occupation in the nation. It's just right behind mining in terms of fatalities. And there aren't many labor protections. So farms that do not have H-2A workers and farms that have less than 10 workers are exempt from providing even workers' compensation insurance. And of course, exposure to pesticides and chemicals and other things is always a risk for everybody in agriculture. So when I have given this talk before, I've asked people to just share their thoughts about what they think these living and working conditions, what this means for COVID-19. And maybe since I can't see the chat, it might be easier if you all just unmute yourselves and share some of your thoughts about how you think this could interact with COVID.
So perhaps with the lack of, adequate, running water and the crowded conditions. So I would think it would be a haven for communicable diseases such as COVID, and it would facilitate the spread of COVID. I think you evidence the migratory patterns of the farm workers, and, we simply could see that, going up across the states in the different regions, that there was a potential for massive, spread of COVID, any, flu viruses, any similar.
Yes. And in fact,
condition.
even before COVID, we saw outbreaks of TB sometimes in work camps just because of these really close living conditions. And then in COVID, being on a bus for 42 hours with people that you don't normally live with, and nobody has had a COVID test before they get on the bus, we definitely saw people getting infected on the bus and then spreading it across the state as they went to different work groups. So yeah, I totally agree with you. Anybody have any other thoughts?
Doctor, a quick question for you would be, when they all gather in North Carolina before they are sent out to their workstations, is that an opportunity for vaccination at that given place?
Yes, for those 10,000 farm workers that are brought in by the Growers Association, that is an opportunity. And we did have 3 successful vaccination days until Johnson & Johnson was just paused. So we're trying. We also, and I can talk a little bit more in depth about our vaccination plan for the state and how we're trying to reach all the farm workers vaccine, because clearly you can't mask 24 hours a day. You can't be socially distanced when you live in migrant housing. So the thing, and they're considered essential workers. So they have to go to work so that we can eat. And so the things that are used by the public health authorities to try to stop the spread of COVID just don't work for farm workers. So vaccination becomes really one of our biggest tools to try to stop the spread of COVID. And last year, when we were able to get into farm worker camps and do testing for COVID, we would find 60 to 90% of them would test positive. So it just, once somebody gets sick, it spreads very, very quickly. One of the things that happens, and I think this is in my next slide, no, it's actually my slide after this, but is that farm workers really don't want to be tested because it involves a loss of income. So if you get put in isolation or in quarantine, you can't work and you don't get paid. So you already mentioned these things about farm workers coming up, spreading the infection on the bus, then fanning out across the state, living close quarters in labor camps. And so, you know, when we tried to do contact tracing for people that became symptomatically ill soon after arrival in North Carolina, it involved multiple health departments, multiple farms, multiple counties. And as I said before, many with high rates of infectivity. Then the other thing about not having paid days off, not wanting to test, not wanting to admit to mild symptoms, not wanting to trouble their grower. So they, especially the H2A workers, even though they're here with documentation and they have better contracts and they have better working conditions a little bit, they are here at the behest of the grower. So if they become sick or if they complain, they just won't be invited back. So that means they really don't want to ask for better conditions. They really don't want to report mild symptoms. They really don't want to be tested. So what really happened last year and what I expect will happen this year is that once one person becomes symptomatic enough to go to the hospital or go to the doctor, then people become concerned and then they want to be tested. But then it's a little bit too late because everybody's already infected. So one of the things that we decided to try to do, and this is where our partnership with you all comes in, is we tried to put, or we have put, a testing station in a place where farm workers just normally go. So rather than trying to get into the work camp to them, we went to the Walmart parking lot in Rocky Mount, where a lot of workers go on Sundays. They're one day off. They show up in their vans and their buses. They do their shopping. They do their laundry. That's their day off. So we put a testing site there. And then because we wanted to destigmatize testing and we wanted Walmart to give us permission to do this, we were able to turn it into a health fair with your help. And so we got, thanks especially to Barbara Knopp, who organized a lot of the instructors in the nursing school and the medical assisting school. You guys have been coming faithfully every Sunday afternoon with a bunch of your students and providing blood pressure screening and blood sugar screening, and that makes it into a health fair and not just a COVID testing event. And so far, almost all the farm workers that have come by have declined COVID testing, but they've been very happy to have their blood pressure and their blood sugar checked. We've been able to refer people with abnormal results to Carolina Family Health Centers. We've been able to provide food support. And this, again, this is an event that's open to the entire community. We're positioning ourselves there for the farm workers, but anybody who comes can be tested. Anybody who comes can be screened. Anybody who comes can get food distribution. So we've been able to provide food thanks to the Harrison Family YMCA and ADLA. And then we have drawn on our connections with the many Latino community-based organizations and farm worker health programs to have enough people there who speak Spanish and who are bilingual and bicultural and can kind of interact with the farm workers and the Latinx community to encourage them to come on over to our little station in the corner of the Walmart parking lot. This is the nurses, and there's Barbara and some of the nursing students from our very first event on February 7th when it was extremely cold and windy. But since then, we've been able to do 151 COVID tests, 92 blood sugar checks, 104 blood pressures, and 207 bags or boxes of foods distributed. We are hoping to partner with the testing vendor called Resourceful Clinical Labs to add vaccines next, and that will be quite challenging in the Walmart parking lot, but we'll see how that works. This is kind of what the graph of H2A farm worker arrivals looks like in North Carolina. So you can see that last year is the blue line, and you can see that we kind of peaked right at the beginning of May. We're a little ahead of that line this year. The yellow line is this year, so we're a little bit earlier this year. but we will probably peak sometime in April. So this is our biggest time for the influx of the H2A workers from mostly from Mexico. And as somebody astutely mentioned, vaccine as soon as possible is our goal. And so what we have done is we have partnered with the cooperative extension agents. As you know, each county has an ag extension office, and they have agreed to help us reach to the growers. And then we have partnered them with our outreach workers who have good relationships with the workers, so that we have this two-pronged approach, one person reaching to the grower, one person reaching to the worker, to try to connect those workers with vaccines on a county-by-county basis. So that is our vaccine plan that we are working on, and we're setting up, weekly meetings, trying to pull together the people who are providing the vaccines, so the local health departments, the federally qualified community health centers, and then the people who can reach out to the farms and to the workers. One thing that has been really exciting is that the farm workers have very little vaccine hesitancy. Now, I don't know what's going to happen with this pause in J&J and how that's going to affect their confidence, but 98% of them are like, yeah, I want a vaccine, I want it now. So that has been really rewarding, and has encouraged us that these vaccine efforts are going to bear fruit. And I think I'm going to stop sharing my slides now and see if you guys have questions. Oh, I see Barbara now. Hi, Barbara. Thank you for coming, and thank you for organizing this health fair that has been, I think, very popular.
No one has any questions for Dr. Thomas? I think you did a wonderful job, telling us about the Latino Health Fair, and you certainly illustrated how we're all part of a whole, and if one of us is weak or affected, then we all are affected by our peers, by our neighbors, by other members of the community. Thank you so much for that presentation and for being here. I'd like to one more time open it up for questions, or
Miss, I got a question.
Wonderful. Who is that?
Never mind. Sorry. I thought I had a question, but I don't understand this thing. My bad. My bad. I'll call you. Bye-bye. Bye.
So I'm going to open the forum now to Dr. Sallie Allgood. Hi, Sallie. Hello, Sallie. I know you were here. Here we go. Wonderful.
Sorry, I forgot to go off mute. I have two screens and it's hiding the mute button. Okay. So thank you for having me here. So I'm going to talk a little bit with you about the community health worker COVID response through the Office of Rural Health and the Department of Health and Human Services. Okay, so I'm actually going to start here at the end and then we'll make our way back to talk about it. But this is some of the impact that our the community health workers that have been hired as part of this initiative are. They've been able to provide housing support in Warren County so that a person was able to cover their mortgage. They were able to provide childcare support in Forsyth County, and not just, support for their children and clothing, but also furniture for their home and food for their family. In Johnson County, they were able to connect individuals with food. So they're able to take care of their family. In Forsyth County, there was a individual that was having to spend money to take taxis to their appointment, and just it was becoming a problem. And so the community health worker worked with this individual and helped her realize that her insurance actually covered transportation to and from healthcare. And so now she's able to use the medical transportation benefit that she had that she was just unaware of. Also in Forsyth County, there was an individual who needed some emergency housing for their partner that was in the hospital for COVID. And so they were able to connect them with the state employees credit union family house to provide a place for them to stay the night. And then in Vance County, they helped a senior who needed a wheelchair but was unable to afford one, get one. And so they're able to be independent and move around freely. These are just a couple of the things that the community health workers that were hired as part of this program have done. So let's just talk a little bit about who are these community health workers. So they're frontline public health workers who are really trusted members and part of communities. They're trained to support individuals from historically marginalized populations. And they're trained on a wide variety of core skills and competencies to better serve their community. Edgecombe is one of the pilot sites offering this training, and we will be expanding that out so that in the fall, additional community colleges can offer this training. So with COVID, we saw that there was, a lot of inequities, inequalities in who was getting COVID, who was affected by, laws of housing, loss of food, loss of jobs. And so the Office of Rural Health applied for the Federal CARES Act dollars to hire community health workers that would then be able to address those social needs across our state. North Carolina Department of Health and Human Services, we selected 7 vendors in 50 of North Carolina's, at the time, they were North Carolina's hardest hit counties. And so this is sort of where the existing coverage is for the community health worker program. Since then, of course, we realized that there's need all across the entire state. And so we just released a RFP so that we will be able to bring in vendors, and we'll expand it to all 100 counties in the state in the middle of this year. I think the expected start is in June or July. And we're also going to realign the vendors so that they're aligned with the Medicaid regions, so that as the Medicaid regions are rolling out, we'll all be in alignment. So the community health workers working as on this grant really have been very adaptable and flexible. We started out that they were doing a lot of work on providing referrals through NC Care 360. It's one of the contractual requirements that they use that platform for all of their referrals. Since these are, a lot of these organizations are community organizations, they don't have robust EHRs to track this type of work. And so we wanted to use an existing platform to do that. They also started to do some contact tracing and supporting that group, depending on which areas they were in. And then we got the support services program. And that was a program that was offered in, I think, 29 of the counties across North Carolina, and that provided direct payment for COVID quarantining and isolation, as well as transportation and food. And the community health workers connected those individuals to those services. And Now with vaccine rolling out, they've been trained to use CVMS, which is the statewide vaccine management system. They are working at vaccine sites providing support. The FEMA site that we had, it was a lot of, we provided a lot of support to that, and just for bringing people in. And then as people are coming into these vaccine events, they're able to say, you know, do you have other needs that we can connect you with during those? And so they're able to connect them with food and housing needs if they have them. So this is just a little bit about NC Care 360, and I'm just going to skip over this for now, but if you have other questions, I can provide you with some information. And really just I think the most important part is just really how agile the community health worker workforce has been throughout all of this. They've been still boots on the ground, working with people when, you know, a lot of people were able to quarantine and stay in their homes. They were still going into work, and they were reaching out to their communities. They were dropping off food boxes on people's front porch, you know, again, doing things contactless, staying safe, but still really being out and engaging the community. So we, as part of this program, 446 community health workers have been hired and are currently working across the state. Again, that's half the state, so we imagine that number will increase when we are able to spread it out the rest of the throughout the rest of the counties. About 85% of the community health workers are women. 91% identify as either Latinx or African American. About a quarter of our community health workers speak Spanish. And, you know, all of them have completed training on how to use CVMS. We're providing additional training on how to talk with community members about vaccination, how to answer questions that community members have about vaccination. And so one of the things that we've really worked on initially in some of our vendors, you know, hired, or we're used to working with certain populations. And we realized that we did not have enough bilingual and Spanish-speaking community health workers, especially in Eastern North Carolina. And so we have developed a lot of partnerships so that we're able to, you know, connect with other organizations that are working with those communities, so that we're better able to, the community health worker vendors are better able to serve the counties that they're working in. So far, we have served over almost 400,000 clients. We have created over 120 referrals within NC Care 360. The way NC Care 360 tracks referrals, about half of those have been closed, but some of the open referrals are ones where you can actually send out, this person needs food and they need food now, so I'm going to send 4 referrals for food at once. So that's why some of those numbers look kind of off. So what are we going to do next? Again, one of the things is that all the work's being shifted to vaccines as well. We're going to be doing a partnership with Healthier Together, that they're going to have a supply and events coordinator. There'll be 2 individuals in each of the 6 Medicaid regions, and they're going to help connect those regions with resources to sort of reach those harder to reach populations. So right now, one of the limitations is just the way vaccine comes, like you can't get allocations smaller than 100 vaccines. And so that's been hard for people who want to go door to door, or you want to go to small, more remote areas where you're not going to have 100 individuals show up. And so they're going to work with the community health workers to identify who are the people that, where are the regions that we're missing, and then the community health workers can work with the Healthier Together representatives to get the smaller allocations of vaccines that we would need to support those areas. And so they can be sort of that in between people to help with that vaccine allocation. And that should, again, go live later this summer. Also, with the new RFP, we're going to be able to continue to support the workforce at the current employment levels for at least another year. And so, again, like I've said, they've shown that they've been very flexible. So post-COVID, we're going to, again, just keep changing their scope as needed and move into primary care support to assist with advanced medical homes, or to ensure people have health coverage, and working more closely with Medicaid. And so that's what I have for you guys. If you have any questions, let me know, or you can always send us an email at ORH later on.
Great. Thank you so much, Sallie. Any questions for Sallie? Great. I think you did a great job discussing the actions, the interventions that have been taken in our Latino rural communities as a result of COVID. And you certainly illustrated the strong correlation between socioeconomic status and healthcare outcomes or healthcare disparities. There's also noted to be a rather high level of distrust for the healthcare community, healthcare workers, healthcare professionals in our most underserved populations. And I think that the healthcare worker program and certificate is a really, really great way to increase that trust and to encourage these populations to seek health improving behaviors, or health seeking behaviors, as we call them. So it's a really, really wonderful thing. So if there are no questions for Dr. Allgood, and if you do, just please interject. Feel free to ask or text or chat.
Yeah, if you put them in the chat, you can answer them there as well.
So I'll go ahead and call on Jennifer. So Jennifer is actually an instructor in our program, certificate program. So I'd like for now Jennifer to actually speak to her experiences as an instructor and what this certificate program is doing in our community. Jennifer?
Thank you. Good afternoon, everyone. I have a short PowerPoint that I want to share with you. As she said, I think Sallie said, a community health worker is a frontline public health worker who is a trusted member of the community, and that is really important. And even before the pandemic, or before COVID was ever even thought of, we had community health workers, and they've been working in our communities for a long time. And the state had already initiated this core competency training because community health workers are needed for a lot of different reasons, not just related to COVID. Some key words that we always think of when we think of a community health worker: frontline. They're out there. They know the community. I just last night was looking because I like to look to share with my students about job openings, and I looked at one particular one, and one of the requirements was that person had to have lived in that community for 2 years. So it couldn't be someone who was just going to get a job and move down there. They had to already be familiar with the community. activities that community health workers already were doing prior to COVID, working on women's health and nutrition. Some of these are hired specifically for a specific topic or disease, and then others are more general. But you can see some of the different reasons why a community health worker would be hired, or activities that he or she would be working in. More specific diseases, a lot of chronic disease, sexually transmitted disease prevention, and maternal and child health are some of the topics that community health workers were working with prior to COVID. And that's important to know, because once we've hired these, we would like for them to continue working. We don't want this to just be a 1 to 2 year existence for these community health workers. We want them to have a long-term profession after hopefully COVID goes away, which is my goal. Some specific duties that community health workers do: case management, risk identification, helping patients just navigate. You saw some examples on the previous slides about helping patients with resources that they weren't aware of. And so when a community health worker sees that that patient has a need, the community health worker is familiar with the resources in that community and can connect them with those. Of course, our community health workers learn about NC Care 360 if they're not already familiar with it. We just had a guest this week who came and talked about it in our class, and probably half of my class was already using it because they're already employed as community health workers. Since COVID-19, we've had an increased need for community health workers. There have been a good number that have already been hired or going to be hired throughout the state of North Carolina. And as you saw earlier, they're helping with food distribution, testing sites. A lot of the community health workers now that are in my classes are busy helping with clinics. Some of them will say, as soon as class is over, I have to go help with the clinic, or I've got to go and help get patients or clients registered. They also provide a lot of education, especially for people who are hesitant about getting the vaccine, as we discussed, and they also can help with translation. A lot of materials are produced in both English and Spanish, as well as other languages, but they provide those. I did a quick survey of my students just to kind of get an idea of what are some of the things that their activities that they're doing. I've had students who've delivered safety kits to people who have been who've tested positive or are having to isolate or quarantine. That includes masks, eye coverings, hand sanitizer. They've gone to the farm sites. We talked about the farm workers earlier to help with getting them either vaccinated, tested. They will actually are taking vaccines there so that they're not missing as much time, because as you saw, if they miss any time, then they are losing their wages. They have translators, food boxes. So those are some of the things that they do. They're also talking with contacts of people who've had COVID to help with educating. I had a community health worker who was a little frustrated because she had gone to make a delivery of a hygiene kit and a food box, and the person she was delivering it to was not home. And the whole purpose of the delivery was because they were supposed to be quarantining. So she had to provide some education with exactly what does quarantine mean. So they're providing that education as well. I was asked to also talk about how COVID has affected our delivery of our curriculum. Our curriculum, we actually started with Community Health Coach in 2016. And then in 2020, we started with the North Carolina Core Competency Curriculum, which Edgecombe is lucky enough to be one of the pilots for. And so before that, we were having classes face-to-face. All classes were done face-to-face, but at the same time, we had local students. I did have a few who were able to drive from, I believe, Gates in Northampton County, but most of our students were from either Edgecombe or one of our neighboring counties, because they couldn't really travel that far to attend class multiple days and hours each week. Since we've had to go to virtual instruction, we right now are doing Google Meets twice a week. They get assignments that they're doing that they have to do along with our face-to-face synchronous learning where they have to attend class. It's not you just do your work online. They actually have to be in class, and we have conversations and discussions. The positive about this is I have students from all over the state now who are attending. I have students from Raleigh, Goldsboro, Wilson, Manteo, Winston-Salem. Those are some of the locations where students are coming from. Greenville. So we have them from all over. So that's been a positive, if you can say a positive, with our curriculum, because if I was still doing face-to-face, it would be very difficult for somebody who lives in Winston-Salem to travel to campus several times a week. We do have some barriers to being able to deliver the curriculum. I am more of a face-to-face instructor. I have lots and lots of props in my classrooms that I use, and models that I'm using to share with students. When I'm in the classroom, I can read the student a little bit better and tell if they have a question or if there's something that's puzzling them. When you're on Google Meets and you have students that look like some of these in this picture here, and all you see is their name, it's a little bit harder to figure out exactly what they're thinking. We would always stop if someone had a specific question and could do a quick search on the internet or pull up information, which I still do that. It's just not quite as easy as it was in a classroom. The other thing is students were able to develop a relationship with each other. Each of my students got each other's numbers and were able to, they kept up with each other even after class ended. And now I don't know that they still have developed a relationship, but it has taken a lot longer. I have a class that's going to end next week, and they really have in the past couple of weeks started bonding a little more than they were at the initial part, just because they only saw each other on the computer, and it's a little harder. It's also harder to do small group activities when you're teaching through a virtual platform. Another barrier to our delivery is that students can turn off their video or mute, and sometimes you wonder, are they really there? So we have to address those issues. I also have students who are just not comfortable speaking, and I understand that. They don't. Every now and then I'll have one who never says anything, who pops up and answers a question or makes a statement or volunteers information, which is very helpful, but they're not regularly ones to speak out. And so that's a concern also. And of course, I use a lot of PowerPoint. So when I'm teaching with PowerPoint, as she mentioned earlier, I can't see chats, I can't see their faces, so I have to stop and then go back and have conversations when we're doing that. And then their assignments, they have deadlines, but sometimes it's a little easy to get behind, especially with everything else that they're doing, because I do try to be respectful of their time. They have a lot of responsibilities also. A lot of our students have been recently hired within the past 1 to 8 months, so they're still learning. Several of my students today were just sharing how much they had learned in this class, because when they first started working a couple of months ago, they just didn't know what was expected of them or what they needed to do. And now that they've had the class, they feel a lot more confident with going out and working with patients and clients. Topics that we cover, health coverage, history of community health workers, motivational interviewing. We talk about, just have someone who speaks about formerly incarcerated transitions, because that's a concern, wellness, chronic disease prevention, maternal child health, trauma-informed care, adverse childhood experiences, mental health. We also talk about professional skills. And then we have one class that ends next week. We have another class that just started. That one's is full, and it's of course currently running. I have another class that's scheduled to start May 4th. Basically is full. I may have 1 or 2 slots left, and then I've got some scheduled to start in August as well. And I'll stop here because I know that we need to let Suzi also talk.
Thank you, Sue. Thank you, Jennifer. So switching gears now, Suzi, what do you have for us regarding your surgical services and surgery. And
Well, let me see if I can get it to come up. I'm going to try that and then that and oh, maybe do this. Let me do this. This and this.
and a little bit of that.
And some of this.
More
over
of this.
here. How's that? Can everybody see that?
Not yet. I'm sure it's coming.
Everybody? Nobody?
Nobody.
Oh, darn.
Nope.
Let me try again. Nothing?
Nothing.
Nope. All right.
Nope.
Well, what I will do then is you'll just have to look at me. I'm so sorry.
Much obliged.
Well, I do want to thank Jennifer and just kind of echo what she said regarding teaching in a pandemic. It's been very difficult, especially for a surgical technology instructor, to know what to do and how to do it, how to say it, especially when we can't put hands on one another or our models or things like that. So surgery in a pandemic world, our initial concerns were going to be the things that we all heard about, of course, the shortage of PPE for our healthcare workers as well as for our general public. We had ventilator shortages, especially in those small community-based hospitals. What happened for the world, as it were, is that we had to stop elective surgery. And that does a lot of different things. The first thing that it does is obviously going to decrease the amount of revenue that all of these hospitals take in. And as we're all aware, our small community-based hospitals are struggling anyway. And so taking away that revenue is going to be a big issue. Another issue is that the bed space that was made available for any kind of surgeries, whether those be a heart attack, those things don't stop because of COVID or any other pandemic. Things like car accidents and all of these other things that happen, that bed space was then reduced in order to facilitate those traumas that come in each and every day. Whether it's a corrective surgery or a therapeutic surgery, all of those things. There was also a reduction in force. We had a lot of staff that were asked to stay home. If you had symptoms, of course, you quarantined for 14 days. Then who's taking care of the patients who are there? We sent all of the travelers home. Lots of hospitals build up their staff by using travelers, whether those are traveling surgical technologists or traveling nurses. All of them were sent home as well. Of course, then we had to gear up all of the testing for all of the personnel, the patients and staff. We had no family members coming in for our patients. So that brought on a new challenge, which then is going to be our communication systems for our quarantined patients. How are they going to be able to talk to their families? Can their families give, consent for these treatments, et cetera? So all of these things were the initial concerns going into this time last year. As far as teaching was concerned, if there is no elective surgeries, that means there's no surgical technology students either. So my students were kicked out of the hospitals, and per our guidelines, we have to be in the hospital. I can't use simulation and make it work. So a long-term effect of that, then an ongoing concern of that, is we're going to have an unprecedented disruption in the provision of surgical education, whether that is our surgical technologists, or that is our nurses, or that is CNAs, or that is our medical staff, whether that's surgeons or residents who are trying to complete their programs of study. We have an unprecedented disruption in all of that. And so this is going to be one of those ongoing long-term effects. I think it's highly likely that we're going to see an uptick in cases of things like breast cancer, colon cancer, lung cancer, heart disease, just because of the recent lack of screenings. No one was going in for their colonoscopy or going in for their mammograms. So with those things in mind, we are now that many months behind schedule, as it were. Again, we're going to have to rebuild the national stockpile for the PPE for the ongoing process. We now look at a new crisis coming about, which is going to be the COVID variants that are now coming around. I think COVID-19 is probably the beginning of a long continuous strain of things, regardless of what they call them or their strength. I think we are going to see this happening more and more frequently. We're now seeing things like dedicated operating rooms for COVID positive patients. We never saw that before. If you were a level 1 trauma hospital, you might have a dedicated trauma room. We now have dedicated ORs for those kinds of patients, for COVID patients. Obviously, continued testing for all patients is going to continue. We have serology testing going on. If the patient has a positive serology, then they are free to have their surgery, especially if it's an elective surgery. In the event that the patient has had their vaccinations, they can again have their surgery. If the patient tests positive, they're going to go home. They're going to wait 14 days. They're going to have to get vaccinated prior to coming back. Again, we're looking at a possibility of a vaccine policy for staff. We see that currently if you are working in the hospital setting, and we have the flu shot come around every year. It's a mandatory thing every year. Is COVID going to be one of those? And that's one of those ongoing questions, one of those ongoing concerns. Another current concern is that we have less available blood products for our surgical patients. Again, we were all quarantining, all staying home, not doing our normal routines. So those folks who routinely gave blood or blood product stayed home. We don't have our blood banks full to capacity anymore. So this is another ongoing concern where we're going to kind of be behind the 8 ball for a period of time until we can again get caught up to those months that we missed in having those things available. One of the other things that we need to talk about is the fact that anytime we delay a surgery of any kind, we tend to have a larger surgery that needs to be done, a more complex surgery that needs to be done. And we also look at the fact that we have subsequent increase in pain for these patients. So that brings about opioid use, pain medication use that maybe we would not have had to have. We have poorer outcomes for every 6 months that we delay a surgery. I read a statistic that said that lung cancer alone is projected to result in more than 3,000 additional avoidable deaths within the next 5 years. And this is all because of 1 year of not screening and treating early diagnoses. Something that Dr. Thomas said regarding the vaccine was that she was not seeing a great deal of hesitancy, and I'm thrilled to hear that. I do think that there's a lot of hesitancy in other areas when you look at, especially now that the Johnson & Johnson has kind of been put on the shelf for a period of time. I think we're going to see a lot of hesitancy in those countries like Uganda, Malawi, South Africa. There's a tendency to believe that the richer countries, the more affluent countries, will hold on to those vaccines. And in fact, many of their people and population have been vaccinated not just once, but twice. And now that we have the Johnson & Johnson halt for these other countries, it looks to them as if we were giving them a substandard product to begin with. There was a doctor from Uganda on the news the other morning who said that patients were calling him and saying, how do I rinse this vaccine out of my system? Because they no longer trusted it. And so I think we have a great deal of things to worry about as far as going forward in how to, what do we need to do? We need to educate the population regarding the efficacy and the safety of the vaccine. I think we also need to educate our population regarding the fact that hospitals are safe, that your doctor's office is safe, that it's okay to go back into these offices and to have these screenings that we weren't getting before. And I think thirdly, it's important that we try to recognize those hesitancies and try to alleviate those things through education. And for those of us who have been vaccinated, just to let our friends and family and coworkers and church members know that we're okay, that we feel like it's going to be a safe, effective way to do it. I tell my students all the time, if there's one person who is suffering from something, we are one plane ride away from the next pandemic. And I really wish I was wrong, but we definitely, on a global perspective, we globally need to make sure that not just our migrant workers and not just our healthcare providers, but everyone gets the opportunity to be vaccinated at some point. So thanks, Jennifer.
Thank you, Suzi. And I think that was a very comprehensive, holistic view of how COVID, you know, with all of our participants, has affected us as a society, as a community, as a global community, as a people. And I do believe I did see a hand being raised. Was that Miss Sessoms? Did you have a question, Miss Sessoms?
Oh, I didn't have a question.
Okay. What you got for us?
I'm just messing around, but
Oh, you didn't?
no.
Okay. All right. Well, thank you for joining us, for being with us.
You're welcome.
Excellent. Thank you so much to all of our panelists. Really great, thorough discussion. So I think now at 4, I'm going to start to end the recording here, but we're going to go back to Carol, I believe. We have a Faces of the Community coming up next. So I believe
Yes,
we're going to
I am
also
here.
go to the coffee house and kind of see what's going on in and around campus.
I'm hidden in the, I might be hidden in the shadows, but here I am.
Awesome. All right.
Let
Let me stop recording.
Yeah,
Okay.
and then I'll start.